do it this year at the Newark Marriott, plenty of parking, and it should be good. We're going to do it just 3 hours instead of the 6 hours we did last year. We'll do 1 hour dinner and 2 hours of really good topics with about 10 speakers or so. Make sure you set aside that date, May 20th. I think the start time is 6 p.m., but we'll let you know as we get closer. Watch for updates on the website. We try and post everything on the website, www.emsfellowship.com. Also, I should say, while I'm thinking about it, follow us on Twitter and follow us on Instagram too. We've been posting lots and lots of stuff for everybody out there. And also, we put our free copy of our book on the website as well as most of the articles. January 2nd is our REBOA conference. We did it specific for the fellows to start doing pre-hospital REBOA. After a great REBOA pre-hospital conference that was conducted by the famous John Holcomb and Frank Butler and everybody else from the military. We invited lots of people, so even if you're not going to be doing REBOA, please come and learn about it. And we'll talk about a couple of things. We are going to do it from 9 a.m. to 1 p.m. and then at 1 p.m. we are going to do Journal Club. That's January 2nd, and we're doing that at the old Monarch Education Building here in Wall Township. And if you want to bring somebody, just let us know. We got a couple of good speakers who do REBOA. And have done REBOA on patients several times. So it'll be a great group of people. Please join us. Let's see what else is coming up. Shout out to North Arlington. I was there last night, a great group of people. It took me back to the old days where they have full crews of 4 people on every ambulance. In fact, they have 2 full crews, and they have supervisors there too. A very progressive first aid squad. We are getting very close in our state to allowing BLS to do albuterol via nebulizer or metered dose inhaler. So we'll keep you updated about that as well. So let's get started. Interesting cases. Who's an interesting case?
So Janae and I actually have an interesting case together. So it was one of those great days where one of us got to be on the road and one of us was in the ED. So we have like a full story to tell you.
So call came out as a respiratory complaint, and that was all we knew. And I was actually with Sunal yesterday too, so everybody that is here now was there. And that was all we knew, was that difficulty breathing. There were no other details offered in the dispatch. So when we got there, we went up into the building that the patient was in, and the patient was like laying in the middle of an apartment building hallway, so half in her doorway and half in the hallway. And the story was that her significant other said that she was complaining of difficulty breathing, and she tried to like walk out the door, in my mind, as if to like try and get help or go to the hospital, and then she collapsed. He said that she was not responding to him initially, and paramedics who beat us to the scene also said that the patient was initially not verbally responsive. She was breathing and had a pulse, but was not responsive. And then when we got there, her jaw was very tight, and she had a lot of like secretions and saliva coming from the mouth and around the nose, but she was starting to come around almost as if she had maybe had a seizure, and that she was coming out of it and now in this confused postictal state. Initially I thought, oh my gosh, we're gonna have to intubate this person here in the hallway, but she came around, so we picked her up and moved her back into the ambulance and got her down to the ambulance, and on the monitor, by the way, up on the floor, she was tachycardic, but her pulse ox was like 93-ish%, so doing fine once we actually got it to read. And she was able to like follow commands when she woke up. We put her on a Reeves, got her out to the truck, and then on the way to the truck, she was like very erratic, like almost like screaming, like, I can't breathe, and she was saying things like, don't let me die, I can't breathe, but she obviously had enough air to say those things, so I was trying to help calm her down, say try not to yell, focus on your breathing and that kind of stuff. And in the time it took us to get her in the back of the ambulance and for me to walk around the back to the side door, she had become unconscious, unresponsive again, and no pulse. So we initiated CPR. She was intubated by the medic, and we put an IO in, and then I told them, I gave them orders to take the patient to the hospital. We were maybe 5 minutes away, so rather than continue to stay and play in the field, it was a witness arrest, so we took her there. She was in PEA, was the initial rhythm for the arrest, and then
What was on the monitor?
bradycardia. So it was a bradycardic PEA. So she did get calcium, and she did get, I gave orders for bicarb. I don't think she actually got the bicarb prior to us getting the ER, but she did get calcium, and 2 rounds of epi, I think, en route that they gave her. So, yeah, that was it.
Did you look at her heart with the ultrasound?
Oh, yes. So before she collapsed, I did not get a good look at it, but when she was in the ambulance, like when we were holding for CPR, she did have a little bit of squeeze still. So it wasn't like it wasn't cardiac standstill. So that was part of the reason why I said to like continue, and rather than stay there, we took her to the hospital. So.
Okay.
And I misspoke, by the way. Sorry, it wasn't Sunal with me. It was Vin. It was one of our residents. Sunal's over there, like, what are you talking about? I wasn't there. So, sorry, that was the day before. That was a different cardiac arrest.
So, when you brought her in, she was still in cardiac arrest.
Yeah, for very briefly. And so, yeah, I think they got through 1 round in the ED, right?
Yeah, so at this point, the ED's already slammed. We have lots of holds. It's just your typical average day. And we did receive notification in advance, which was fantastic. The patient was coming. We were ready for her when she got there, and we started CPR. And the first thing we did during our first rhythm check was throw a probe on her heart, and we did notice that she did have some cardiac motion, which was fantastic. So when I think of a PEA arrest, especially a woman who's complaining of shortness of breath, I'll put this out to the group. What's the first thing that you think might be going on?
Right.
PE, right?
Yeah.
So that's the first thing I thought too. And during that first round of CPR, I'm thinking, well, if we don't get this lady back, like, should I be pushing TPA at this point for a massive PE? But when we looked at her heart, it was weird. She didn't have any RV dilation. She didn't have any sort of thrombus. It was pretty normal, actually. It was some like global hypokinesis, meaning that, overall the heart wasn't moving that well, but there were no other signs that this could be a PE. So we were very confused. And one of the most interesting things that we found when we did get Rosk was that we checked her blood pressure, and it was 220 over 110. And it stayed that way, and we hadn't given her epi in a while. So,
and the only medical history that this woman has been diagnosed with was diabetes, and that was it.
Nothing else before.
Right.
And the other thing that we noticed after we, got that blood pressure is she started to have a lot of frothy sputum coming up through her tube.
Okay.
So now-
All right. So let's hold the case now. So in a perfect world, you would have done a TE.
Yes, I actually
Okay.
brought it into
Okay.
the emergency department with me because they were going to continue doing, I assumed they were going to continue doing compressions. So I was going to use the TEE to address the compressions being in the appropriate location and that kind of stuff.
So maybe you would have been compressing the left ventricular outflow tract over the aortic valve,
Right.
and actually been hindering good compressions instead
Right.
of helping.
But we did get Ross, which is a good thing.
Right.
So the TE wasn't warranted at that time.
So because she was in PEA with cardiac movement, did you consider stopping CPR and giving her push dose pressures besides giving her calcium, thinking maybe she was hyperkalemic?
So in the
Because
field,
maybe her blood pressure was 50.
right. In the field, we did not do that because we were only on scene for maybe 5 minutes, so we kind of just loaded and went, and they continued ACLS protocols. I think maybe if I'd stayed in the squad with them, I may have given that order en route, but I wasn't thinking about that before we left
Okay.
because she'd only been down for a short period of time. So, yeah.
Will Fleming was asking what was the blood pressure in the field, and would it be potentially better to use a stair chair as opposed to the Reeves, giving her having
So-
some shortness of breath?
Yeah, so actually initially they did bring up the stair chair, and then they realized that the patient was not really able to sort of stand and move in any way on her own, and because she became too short of breath and she was still altered, and so we made the decision to just take that risk out of it and just put her in a Reeves because she was like on her back out in the middle of the hallway. You know what I mean? We would have had to physically like sit her up and then make her stand to get her into the chair. And then the blood pressure, we never got a blood pressure in the field that I remember. Actually, I lied. She was hypertensive in the field when she was coming around. If I'm remembering correctly, I want to say it was like 180s over low 100s. And then obviously when she became unresponsive and went into arrest, they weren't able to get a blood pressure at that time.
Right. So were you thinking maybe she's having a head bleed or something?
I thought that she, initially, like I said, I thought maybe she had a seizure. And then when they were explaining to me how, like, quickly the shortness of breath came on, or the way the husband was describing it, and then her continuing to complain about it and almost in, like, panic mode, I was thinking PE that whole time.
So like a hypoxic seizure or something like that?
Yeah.
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 So it does get a little bit more interesting. So, we also consider that, and it's funny that you mentioned like a head bleed, because eventually a family member showed up and I discussed everything that had been going on with him since he was not there on scene for them. He was meeting them at the hospital, and he said that she had been complaining for a headache for the past week. As well as her breathing was strange. She said that she would take like a couple of extra breaths and sigh and, have this like loud breathing that was abnormal, and he wanted her to get checked out, and she's like, yeah, I'm fine. And she didn't do it, which is okay. But
Because what do we, subarachnoids I know are associated with prolonged QT, which is associated with torsades. I know the association between subdurals and ventricular arrhythmias. PEA, I don't know. I know there's associated with PEA and subarachnoids. But, certainly you can have all different types of breathing with intracranial pressure elevation. Right.
So it turns out that, after she got ROSC, she remained persistently tachycardic but stable and hypertensive. And I mentioned before that she had a lot of sputum coming up through her tube, like very significant amount. I have my respiratory therapist suctioning. So in terms of managing her now that I had her, she was still very hypoxic initially. So what we ended up doing actually is we increased our PEEP significantly on our vent, because it was kind of apparent to us at that point that her lungs were filled with fluid for some reason or another. So because of the pulmonary edema,
Because you had room to go to, right? Because she was
Yeah.
hypertensive. So what did you put your PEEP on?
we started up at like 12 to 15 actually, and she did fantastic. Her SATs came up, her tachycardia was still a little bit persistent, and eventually we called for a stat echo. We had them come and do a formal TTE at the bedside, and what they thought it was, at that point was actually a new onset heart failure or hypertensive emergency that had been gone undiagnosed for this whole time. And we did send her to the CAT scanner, and we scanned her head, and just for completeness sake, we scanned her chest to look for a PE, and both of those were negative, except she did have a lot of fluid in her lungs. So we also gave her ADL-A6 to start her diuresis, and I know the most important thing is what do we do with the blood pressure here. So in that case, we gave push-dose nitro. We were giving like initially 600 and then 1,000 mics, so she got a few times. Started her on the nitro drip, got her pressure down, and she did really good.
So she had de novo heart failure, systolic dysfunction. What was her EF?
I don't know that I had the results at the time, so I could get back to
Any pericardial effusion or pleural effusion?
No, but just a lot of fluid everywhere on her lungs, like almost a whiteout of her.
So could this have been from like ischemia or infarct? Did she make tropes?
I could go back and check. Actually, right now.
Yeah. And then, of course, you worry about with acute right-side heart failure, a big PE, although that's very rare, and she had more than right-side heart failure anyway.
Right.
So maybe her hypoxia was causing her PEA, and that's caused the cardiac arrest, right? I'm just thinking about the cause of the
I
PEA.
think probably the respiratory came first. It might, like looking at it, actually, I'm glad I got to stick around and see the chest X-ray. Was pretty impressive. It looked like ARDS actually,
Right.
And so I feel like she had to have been building up that fluid for quite some time, and I guess maybe she just hit her capacity for hypoxia, and.
So we have no medical students here. How come we have no medical students here? What is ARDS? ARDS. So, I don't know. To me, ARDS is a pulmonary capillary wedge pressure less than 18 with a PO2 to FiO2 ratio that's less than 100 with, and if it's less than 200, it's acute lung injury. Is that right?
Yes.
With a white fluffy pattern on chest X-ray.
Mm-hmm.
Right? Is that what ARDS is?
I think less than 100 is severe. I think less than 300 is considered ARDS, but if it's less than 100, then it's like severe ARDS.
Yeah.
But yeah.
Did you look for like lung sliding and stuff? Did you do like a lung ultrasound?
Yeah,
I did not. They did it.
we did it in the ED, and there was very clearly B lines kind of all over the place.
All right. So you knew before the X-ray.
Yeah.
So basically, this lady, just if she's really de novo heart failure, a little bit of diuresis, if her renal function is normal and her albumin's normal, should help her a lot.
Right, so
And bring
after-
down her blood pressure, right? I mean, she should have
Yeah.
been easy to fix. Do you remember, was her renal function okay?
She was making clear yellow urine. I'm trying to pull up.
Because how do you dose Lasix? People don't know how to. We've written papers about this. And I always say in 2019, I still don't know how to dose Lasix. And we wrote the pre-hospital paper about giving Lasix. With GFR and how it really doesn't, even though it affects it, brings it back down to normal. Lasix is based upon albumin and renal function. And you don't know either pre-hospitally. If your albumin is low and your GFR is low, you need 200-300 of Lasix to pee. And if you have normal renal function, normal albumin, you could need 10 or 20 to diurese. It's not something silly like 1 milligram per kilogram, right? That's a silly way. That works in babies, but in adults, it's kind of a silly way to diagnose to give Lasix, right?
I know in the House of God they said age plus 20 or age
Right,
something
right.
like that.
Age plus something equals Lasix dose. I forget.
Exactly.
Yeah. But but that's silly.
As a silly-
So I bet you helped her a lot. You probably caused her to diurese a lot. She probably got better quick.
Yeah, after we gave her the 80, she put out a liter within like an hour.
Yeah.
So she got a lot of that fluid off, and she did very well. And then there was a question of whether or not she had an abnormal rhythm, because she had some tachycardia, like in the 130s, 140s. They got a little bit wider an hour, but nothing really consistent with an AFib or consistent with
Right.
a VTAC. So they were thinking that she could have had some myocardial scarring or stunning from maybe silent MI or something. that she
Yeah,
never
of course,
even
and
knew
that's what's
about.
causing all this. Of course, I'm sure they measured the left atrium. If the left atrium is bigger than the Pension's article you read, 4.5 centimeters or so, you're at high risk for AFib, right? And you're at high risk for an AFib that's difficult to convert back to sinus rhythm, right? Because the number one cause of AFib in the United States, at least, is hypertensive cardiovascular disease. Long-standing hypertension, making your left atrium bigger and bigger, until you go into aflutter or AFib or something, right?
Right. I think it's this is, I guess, kind of on a sidebar note. I think it's pretty important whenever you see a patient in the ED who has hypertension or even borderline hypertension, the 130s, 140s, maybe they're not there for that. I always send them to go follow up with someone and get it rechecked.
Yeah.
And I'm thinking, like, it might not hurt to do that pre-hospitally either, just be like, hey, maybe you're releasing on scene, your blood pressure's high. I know you don't want to come to the hospital, but, this is something that can be a problem later on, and maybe
Right.
save someone's life that
At
way.
least
by sending to the
documenting it.
doctor.
Right. Will you start oral medicines for somebody who signs that AMA?
Absolutely, yeah.
Yeah, me too. When I first started out, I didn't do that, and I was doing the wrong thing. It's because some attending told me that I'm not allowed to. I remember this years ago. Some attending told me I'm not allowed to start blood pressure medicine if somebody's signing out AMA, and of course, I made a mistake in not saying why is that. Instead, I just listen to that person, and that's crazy, right?
Right.
Why can't people be on? If somebody signs AMA, I'll still give them whatever medication they need. You don't have to punish them, right?
Can we talk about that for a hot second? Now, I know this is more of an ED question, but I'm curious what your go-to, like, if you're diagnosing somebody with high blood pressure in the ED and you're going to send them home on something, do you have a go-to medication? I see you prepping like you're going to answer too. I'm excited about this.
I mean, go ahead, you can answer first.
So it honestly all depends. So when you talk about from an ED perspective, and if you think about different patient populations, so if you work in an urban setting like ours, and like where I work, and I typically know from like what JNC kind of recommends in terms of African American populations, like kind of you want to go towards like a diuretic like hydrochlorothiazide. The issue with hydrochlorothiazide is that you kind of have to watch the renal function pretty closely. So if you have someone who's got poor follow-up, that tends not to be the best choice of drug. So patients who have bad interval follow-up, that's not probably my choice. And a lot of times if I don't do any labs to begin with and I don't know the patient's renal function, I may be more hesitant to actually do that. So if I decide, okay, I got LVH on the EKG, someone's got persistent hypertension, last visit they've had this, I'm going to decide on prescribing something, then I would say the hydrochlorothiazide, if I did labs and I said maybe if they got good follow-up. If not, my go-to's more of a calcium channel blocker, more like amlodipine. So amlodipine for me is a better choice, and it's also a second line
Small
kind of
percentage
medical
people
treatment.
that amlodipine get edema. some of
Right.
the people you may be seeing
Sure.
get edema, but you have to watch out for that, right? I mean, hydrochlorothiazide, you can start at a very small dose, right? And
Right.
it's easy to take, it's cheap. At 12.5 milligrams, nobody gets hypokalemic, right? So you have to worry about hypokalemic. At 25 milligrams, a small percentage of people get hypokalemic. If you're not measuring the potassium in the ER, which you probably should be for undiagnosed hypertension, if not doing a much bigger workup, it's, I might not start it. But if I had a K that was relatively normal, I mean, I would probably start at 25. And if I had a K that's borderline, I'd probably start at 12.5. But, of course, we all know what's really important is the follow-up, not what drug we
Right.
start. But, I mean, and right, African Americans do tend to need a little bit more of a diuretic. But, I mean, ACE and ARB, I start on most people. But, who knows what it's going to do? It needs to be titrated up, right? This is what was explained to me when I was like a medical student. Some nephrologist said, Mark, you want to treat all this blood pressure in the ER, stop doing it. They're going to go home and mow their lawn, and the blood pressure's going to go way up. But you're not there to give them like lots of drugs, right? And it's true, right? So blood pressure is a problem over days to weeks to months to years, right?
signs in ACE?
I think for the average person, but African American, I will start more people than not on hydrochlorothiazide. But I mean, ACEs are easy. I mean, I worry about left ventricular, remodeling, or at least that's what I want. I want some LV remodeling,
Yeah.
which they probably have, some LVH, and I can get some remodeling done with an ACE or that ARB. Plus, I can probably find a once-a-day drug, and and it's convenient. And I obviously get something that's off patent, so it's less expensive, right? But it's not us. It's not the ER. We're just the guys who are starting the meds, right? What's going to happen after they leave, and that's going to need to be readjusted. I'm sure you guys would do the same thing as starting somebody with a blood sugar that's a little bit high on metformin, right? I mean, I would do it, right? I actually just started on metformin ER, like a 24-hour metformin, because to put somebody on a TID metformin in 2019 almost, I think it's silly. People can't take TID drugs very well, and even BID drugs are more challenging. But I still see people writing metformin TID all the time, and like you can do an ER, metformin ER. There's a 24-hour drug now, right? So it's easier, and I mean, why not? What's the downside? We now have a good benign drug, right? Any other thoughts, Chris? What are you doing? What are you being taught, Chris, for? Borderline blood pressure, maybe they'll follow medical clinic, will they not? You're going to start blood pressure medicine in the ER?
So no, actually, kind of the teaching that we're having up where I'm from is to have them follow up closely with cardiology. We have both ER...
For high blood pressure?
Yeah, I'm sorry. Yeah, for high blood pressure. So we have an ER cardiologist that sees them when they come to the department, and then we actually have our cardiology sets them up with an outpatient appointment in the next 3 days in order to get good follow-up for hypertension.
That's awesome.
Yeah, because a lot of ways I feel it's a little dodgy for me to start a medication that I'm not sure if they're going to continue taking or take appropriately or have good follow-up for lab values, and what if they overshoot and become hypotensive or have issues with vertigo. So I'm actually kind of on the same page though. Like, good follow-up is very important for...
But that cardiologist has to start a medicine in the clinic or wherever they're seeing the patient, right? So I guess the harder question is, what % of people don't go to that appointment?
I
Right?
don't
So
know.
let's say somebody studied that and found out that 20% don't go to that appointment. You just have the same philosophy?
So we kind of cheat because the cardiologist many times will actually start that medication in the ER when they actually evaluate them in the ER.
Right. Do you think your risk is, do you think that cardiologist risk is higher than yours because they're starting it?
No. My concern is if they don't make that follow-up appointment, it doesn't matter whether or not I write that prescription, because they're not going to get the refill. They're not going to get the
Right.
continued care
Right.
that...
It's true.
So
So
whether I get
it's
30
a
days or not.
cardiologist. I mean, the renal guys really own hypertension, but they're not going to hang out in the ER, right?
True.
But I mean, really, any internist could do what that cardiologist is doing, right?
Absolutely.
Or I mean, for that matter, any internal medicine resident could do that too,
Exactly.
right? This is not hard, it's just a matter of the compliance, right? Interesting. What'd you guys do in your residence?
Um,
Did you start medicines in the ER?
I think I did residency in a place that's a little bit more similar to Chris than the urban environment that I'm in now. And there we would probably give a week's worth of meds, whereas now I prescribe a month's worth of medication. Because I know
Yeah.
it's going to take a little while for that patient to follow up.
Right. What'd you do?
It definitely was attending dependent. Everybody kind of has their own idea of how they want to handle.
And isn't that
kind of
silly,
thing.
right? I mean,
Right.
the best way to care for patients is a protocol, so we're all doing the same thing.
Right.
Agreed, yeah.
That reduces your risk.
Right. I think the majority of my experience was surrounding some sort of arbitrary cutoff in the attending's mind, like if their blood pressure is like 200 over 110 or 220 over 90, whatever that number was that made them uncomfortable, then they would probably start them on a medication like amlodipine or hydrochlorothiazide and send them home on it with good follow-up. And
Right.
usually, if I'm writing medicine now, I definitely give 30 days, not even necessarily because I'm worried they won't follow up at all. Even if they do follow up, sometimes it can take that long to get in to see a primary provider. So I feel
Yeah.
like I don't feel like there's anything wrong with that, or even giving like 2 refills of it, like so that they have something. Because in theory, you're prescribing a fairly benign medication, and then I always make sure I just give good return precautions. If you start to feel dizzy or lightheaded, or you have muscle cramps or anything like that, along with chest pain, shortness of breath, all that jazz, then you should come back and see me.
Yeah.
So.
Okay, good. Anything else with that case, Joss?
I was just trying to look up some numbers, and it looks like her trope did not really elevate, which is kind of fascinating. EPS saw her like at electrophysiology. They have her on an amnio drip, but no VTAC. Nothing.
So
like
they must have her on the amnio drip for some reason. I mean, did
She
she?
never the arrhythmia.
Yeah, she must have had some arrhythmia for somebody somewhere.
that.
Yeah.
Right.
Right, there's
And-
got to be some reason, like maybe she had another cardiac arrest, which they documented VF, and they're
Yeah.
keeping her on amnio drip till they can put in like a pacemaker cardiac defibrillator or something.
She had. I know that when she was in the ED, she had some PVCs, and like it looked just generally like irritability, and
Right.
no one was 100% sure. So that's why I think that was started. And then I think the other thing I followed up on was that in this type of patient, just like any other patient in general, which has a very short cardiac arrest, like that was witnessed, and we had quick ROSC, but she wasn't following commands. She's a good candidate for therapeutic hypothermia, so that was performed.
Yeah. All right. Maybe. So give me that pre-hospitally. The literature is terrible about pre-hospital hypothermia,
Correct, yeah.
right?
We know that doesn't work.
We know that in the ER, it's a nice, healthy academic debate whether there's what the use is of hypothermia in the ER and the ICU. So it would be like a 3-hour discussion with data on both sides. And I guess the bottom line is if you do it right, it's probably okay for most people, right? But if somebody didn't do it, I'd be okay with it. And if somebody did do it, I'd be okay with it. That's where I'm left with the literature,
Right.
right? Another interesting case, anybody?
I think we were at FEMA last week, so I'm trying to think back to before that.
We can talk about that if you want.
Oh, sure. Can you talk about, if nobody has any other interesting case? No? All right, go ahead. Just talk about FEMA for a minute.
Yeah. So, I recommend that everyone in the world does this. So it's completely free. This is my word of mouth getting to everyone here.
You keep telling people this won't be spots for fellows.
Right. Well, so not everybody, but some everybody's. Basically, Janae and I both got to participate in this class where we went down and we met a group of incredible people from all different types of walks of both pre-hospital EMS and in-hospital providers. And it was basically showing us how to respond to an MCI from the command center perspective of having a role in the incident command system and how everything plays out from a simulated event that occurs from the time you're sitting in your office doing regular stuff to seeing that breaking news brief to responding to actually what happens in the ER. So it was a pretty cool experience that we got to do. So I had to play the role of a medical technical specialist where I got to look up what was going on for this bioterrorism attack and make recommendations. And Janae had a pretty cool job too.
Yeah, so they made me operations chief. So it was actually kind of funny when you get to this course, you get to list like what are your preferences, where do you want to be? Do you want to be in incident command or public safety or whatever? And we both said we wanted to do incident command because the whole point of this training is for us to learn something that we haven't experienced before. So then the day that we got like assigned our roles, because we had done some tabletop exercises, and then Wednesday, Thursday we did actual like run-throughs of events, and then Friday was our capstone event where we combined with the hazmat training course to do an event together. And they laid out this sheet on Tuesday afternoon that like had everybody's roles listed in there, and my name was listed as operations chief, and there's this really long list of other names underneath me, and I'm like, there's a lot of people that I'm in charge of. I was like, I have never done this before, so I actually like had to print out like a sheet with like my duties and things like that to make sure I was like aware of all of the things I was in charge of. So shout out to anybody that has ever been an ops chief on any sort of incident command, because it was a lot to think about at once, with everybody coming to you with, I need this, I need that. You had infrastructure and hazmat underneath you, plus both the med branch. We had 2 med branch directors in this scenario, one for the ED and one for like all the floors and the ORs and that kind of stuff. It was a lot to keep track of, but it was an awesome experience. I definitely feel like we have a better understanding of how to set up an incident command structure. We have a huge list of questions for ourselves, like where is our emergency ops plan in the ED that we work in? And like if you don't know where that is in your ER, you need to find it, because when something goes wrong, the ER is the front line, and if you may be the first person to know that there's something bad going on out there, and you have to recognize it and like potentially be the one to activate incident command. So it was really cool. Yeah, I liked it a lot.
Can you like just say 1 or 2 things you learned that you absolutely didn't know?
Yeah, oh my gosh, I have to pick one. One of the things that I didn't think about was an issue with like the water supply. Like what do you do, and what happens if the water supply to the hospital is completely contaminated and you can't utilize any of the water for anything other than like flushing toilets? And how do you like make connections with the outlying companies in your area to set up a freestanding agreement for those sort of resources and support systems? So I didn't even realize that was a thing that hospitals have, were those standard agreements with surrounding facilities and like Walmart or Costco or whatever it might be. We're not sponsored by anyone, just to clarify. But yeah, I didn't even think about that as a thing. And then what was the other thing I was going to say? In terms of like ordering stuff from the national stockpiles. I'm sorry, hopefully I'm not stealing your thing here, but one of the cool things was being able to watch Jocelyn and like help and together kind of figure out how much of a certain medication we were going to need as an antidote for our potential exposed patient population, and how do you go about ordering that or requesting that from like a national supply. So I had no idea how to do that before this course. I mean, the details are different everywhere you work, but at least I have some general idea now. So.
All right, great.
Right, I think that there's 2 things I learned. One thing was not to react to everything that you hear, because one cool part that they did in this exercise was they threw out all these random things, like they give us fake phone calls, like a bus rolled over like a mile away, and you're like, oh my God, let's call the ED and be like, how many bus patients do you have? And they're like, we don't have any. And it was just like a joke. They were all going to the other hospital on the other side of town.
You have to vet your
It's always been my philosophy for these events to actually, you're going to think this is strange, to not give all the ERs every little detail of what's going on.
Right.
We get a report of 20 patients. When we call the ERs and say you're about to get 10 patients, they tend to freak out.
Right.
So until you confirmed it, don't just think you're doing the right thing by letting all the ERs gear up for all the potential patients.
Exactly.
Because we've been on the other side of the ERs and see what they do. Make sure you've confirmed it before you give the ERs information.
Right. And I think another thing that's just so important, and we talked about this with the after action report from 1 October, the Las Vegas shooting, was having these systems in place now. So not kind of waiting for something to happen, but having drills that involve like local squads and hospitals. So if you're a first aid squad out there, or your medic program doesn't get involved in anything like this, talk to one of the hospitals, talk to the medical director, see if there's a contact person there, and say, hey, when you guys do your ER drills, like, we want to come play. So we know how to make those phone calls. And,
right. And I say this all the time. The people who are being tested when you do your drills are not the people who know about EMS. and
Right.
doing drills. They should be the people who are the daily workers who have no experience, because ultimately when something bad happens, it's never going to be us who's there. We're going to be coming from a home or somewhere else. So it should be the people who are not involved in all this in the ER when we do the drills they're the ones who are taking care of the patients, right?
Right.
Until we get there. Because the silly thing people do is we should be the evaluators, and we can't be the ones who are tested, right? Because we have more experience. However we do is not going to be how it's done in real life, right? And whenever you do a drill, you have to include, you have to also include EMS, right? EMS has to be part of every single drill, and so does the ICU, and so does administration, and so do all these people, so they can work together, right?
Absolutely.
Okay, let's do the articles. Which articles first?
Yeah. Okay, so this was an article that we had posted previously to that we didn't get to, that talks about emergency medical providers' perspectives on like pediatric calls, and it was a qualitative study. I actually really enjoyed reading this article because I could relate to a lot of it after having been involved in a pediatric code earlier this year, and really in general, I think a lot of residents in emergency medicine, not just EMS providers, can relate to the fact that I don't think anybody ever feels like you could get enough pediatric exposure, because there's just something about kids that make people nervous, and that's what this qualitative study looked at. So basically they took 17 providers from both rural and metro regions, actually with Allina Health in Minneapolis, which is where I'm from. And they talked to them in sort of like a community meeting space about, they kept repeating about 5 different points. So they talked about their responses that they believe are the reasons that pediatric calls are so difficult. So the 5 big things that they listed were the special social value of children, the clinical difficulties with pediatric patients, added acuity to already challenging calls, caregivers as secondary patients, and the 5th was identifying with the patient or patient's family, i.e. if you have a child yourself, it's difficult because you can see that child that's sick in front of you as your own child. So those are the 5 big recurrent themes in terms of people's responses as to why they found the pediatric calls difficult. They did offer I thought this was interesting, a $50 gift card as a bonus for participating in the focus group. But basically, the article kind of listed stuff that we already knew, right? So children, in general, people perceive them as having more life to live, so losing a child is harder to handle because you feel like they're missing out on so many other things. Their medication dosages are weight-based rather than just a standard dosage that you can give to everybody no matter what their size. So that makes it difficult because most people don't have pediatric medication dosages memorized, so you can't just rattle off, I want this, this, and this number, unless probably like the PALS drugs, the ACLS type of drugs for cardiac arrest. But you have to get out the Broslo tape or whatever app it is you use on your phone, and you have to read it, and it's just all these extra steps when you're already nervous. And so it feels like even if the code or the call goes well and the kiddo makes it to the hospital, I feel like you still always feel flustered because you feel like you weren't organized. And we don't do as many practice drills, at least I did have this experience, like going through pediatric stuff in the back of the ambulance and like making sure that you know where everything is at all times. So I think that was one thing that they mentioned that you could do to improve, is to make sure you go over your pediatric equipment just as well as you go over your adult equipment, and knowing where it's at and how it's organized.
So like
that
mock
kind of thing.
pediatric codes.
Yeah, but also just like, every day when you get in your truck and you check your supplies and you make sure you have the number of nasal cannulas you're supposed to have or whatever when you're going through your inventory. It's not just about looking and making sure you have all the stuff in your peds bag, it's about remembering where it's all at inside the peds bag so that you don't have to dump out the entire bag to find what you're looking for. Because if you don't use it every day, then you don't remember where it's at, So that was one thing that I thought about. And then I'm not going to list any apps. If anybody wants to ask me directly, you can definitely personal message me. I don't want it to seem like I'm supporting something that I have no financial stakeholder in, but there's a really great app on my phone that I really like that basically has an electronic version of the Broslo tape, and so you can look at the kiddo and estimate their weight, or just based on age use this app, and it has every med that you could possibly want on there. And
Or use the Hantebi method, right?
Yeah.
Which we have a clinical pearl about.
Yes. So that makes me feel comfortable. That's like my crutch when I have a sick kid, because we just don't see it very often, especially now, like at the hospitals that we work at this year, the peds are not integrated into our daily, patient, what's the word, rotation was what I'm looking for.
Which is
They're
really the
separate
future of
departments.
emergency medicine, right? Because
Right.
the future is every peds departments will be separate.
Right, which is good and bad because, and at least for me, the thing I don't like about it is that every once in a while I am going to get a sick kid for whatever reason, potentially, and I just feel like we get more flustered when we don't get that regular exposure. So, I don't know. Yeah.
Any other comments about this paper? So, yeah, it's interesting. I think most people, do you think a peds airway is harder or easier than adults in general?
I think it depends on how big the kid is and what the airway issue is. I think
Right.
in general it's probably easier.
Yeah, so I think most people that I've asked that question to over the years say peds airways are easier, it's just more nerve-wracking.
Right, exactly.
Right, and peds is all the amount of peds you take care of on a regular basis,
Right.
right? The more you do, the better you get, right? I mean, when I first finished my residency, I did 50% of my shifts in the peds ER as an attending, and I think I got much better than I ever did as a resident because now I was responsible and I had to do stuff. I did more central lines on kids when I became an attending than ever as a resident, right? And because there's nobody else to call at night, right, for that critical kid.
Right.
Yeah, so you have to do peds mock codes, right? You have to do them over and over. And you have to confirm babies. You have to do them like on toddlers, etc. I mean, Josh, you probably take care of more kids at Hatzola than you probably have a higher percentage of pediatrics than most every other BLS unit in the state.
At this point, it's probably close to 50-50.
So that's like freaking amazing, right? I mean, I would venture to say that might be the highest in the country, right? 50% peds might be the highest in the country. So you would probably agree that people you work with are probably better at pediatrics than people who are not seeing that many.
Certainly more comfortable.
Right. Especially now that we're heading into like bronchiolitis season, right? So this is the time period that the peds EM people dread because their volume goes way, way up. And you see a lot of kids who have severe shortness of breath, right? And the good news is most all of them will be like okay, and very, very, very few will wind up needing to be intubated. And kids can tolerate hypoxia and low sats really well for the most part, right? So, but you have to get used to a kid like huffing and puffing and looking, and with a bad pulse ox, looking really tachypnic and not so good, or you will freak out all day long every day, right?
Absolutely.
And that's what unfortunately happens sometimes pre-hospitally with people who don't see these kids all the time. You have to just expect these kids to look bad, right? And how do you do that until you see a lot of kids who look this way?
That's the only way to do it, is the experience. It's the street experience that you get, that you see it. Otherwise, you're right, when we first started, you would freak out. You'd see a kid like what we do here.
Right.
Today, we're comfortable with it.
Right.
I think the only other thing that I would add about this article that I thought I had some really good teaching points and recommendations and just acknowledgement of coping mechanisms. One of the ones that actually kind of made me laugh a little bit was very true, was like people using sarcasm and dark humor to like get through
Right.
these tough things. And I think that's a universal truth. So, if anybody ever hears me make a joke, it's because I'm coping. No. But I think
It's
the
on YouTube.
right, yeah. Just, to put it out there, to remember that you're not alone, that some people don't like openly speaking about it, but I guarantee you if you turn to the provider next to you and say, can I talk to you about this? Like, do you think I did the right thing? Or can I just talk to you about it and run through the case with them? I'm sure they would want to listen because that's a way for us to learn from each other and a way for people to cope. So, just try not to, if you're dealing with it, you're having a hard time handling that, don't go at it alone,
Right. And you always have, at least two patients. You always have the kid and the
parents,
and the
yeah.
parent. Yeah.
Yeah.
Every single time. All right. Anything else with this article? No. Okay. So, God, I never could have become a general pediatrician. That's one thing I'm not capable of what a general pediatrician
No.
goes through.
I also remember specifically talking to my husband about pediatric emergency medicine. I was like, I could never do that. It's terrifying. God bless all pediatric ER providers because
Because so much of peds ER is general pediatrics.
right.
Yeah. The okay. What article's next?
you want to do yours, Jocelyn, on transfusion?
I can just talk about, it's a follow-up to what we talked about last week regarding whole blood, which we're very excited about over here because we'll be getting it soon. This is a follow-up article in Transfusion Medicine by Yazer, and it's explaining basically just gives some definitions about all the 19 programs now who are using low titer group O whole blood for civilian trauma patients.
Right, so it's low titer, meaning low A, low B, whole blood. So we just call it low titer whole blood.
Yeah, they call it, I think it's LTOWB.
Right, yeah, that's the new catch term, right? LTOWB.
So I like it.
Do you have any LTOWB for the patient?
Yeah.
2 units of LTOWB stat.
They should probably figure out how to take a couple letters out of there to make it sound a little flowier, but that's okay. So again, what we're talking about here basically is type O whole blood that has some of the antibodies taken away, because as we know, if you get a blood transfusion and your components don't entirely match the donors, you can have a reaction,
Yeah.
which can be very serious. So in this case, they've gone out of the way to try to take away some of the antigens and antibodies that have caused that problem. So basically, this article just goes through what's going on with these programs. So in 5 of these groups, this blood is being used for both trauma patients as well as non-trauma patients. So your GI bleeds, vaginal bleeding, any massive bleeder. So we're taking something that was primarily used as a military product for battlefield bleeding and applying it to somewhere else. So I thought that was pretty cool. And the other 11 programs are still doing trauma patients only. So it's good to know that some programs are using this for things that are outside the realm of trauma. And what else did they say that was
So when I was in Houston, Cypress Creek, Harris County 48 said they were doing 4 times more medical patients than trauma patients for whole blood.
I found it
So
very
4 to
interesting.
1 ratio, right?
Yeah. I mean, if you think about it, which patients are you really seeing in the field that are bleeding more often than not? It's not probably a trauma patient, depending on
Right.
where you are. It's a GI bleed or
It's a GI bleed, right?
Exactly.
Hypotensive, non-compressible truncal hemorrhage, GI bleeding. Right, most people who have postpartum hemorrhage or ruptured ectopic are not hypotensive, right? Most people aren't.
right, unless they're unresponsive and
Yeah.
you're not too far. So they go on to, in this article, discuss what happens to the blood and how it's stored. So programs have different amounts of time that the blood is stored. Some programs, it looks like the majority had about 21 days, but the products are good for up to 35 days. And what's pretty cool is that they have recycling programs where basically they take their whole blood to a, I guess, blood recycling center, if you want to call it that, through the hospital, and they break it up into all different components. So I know in some systems now that are using just regular PRBCs or FFP, once it's getting close to its expiration date or it's expired, it's done, you throw it out, it's garbage. But in this case, I thought that was pretty neat because this is obviously a valuable resource.
So teach me about this more, because I tried to get somebody to do this, and they said the system set up for recycling is $160,000 was the price quoted to me. So if you take the whole blood and break it down into components at like day 34, right before it expires, does the article say anything about can you just turn it in and right before it's due to expire, and then you can get components out of that? Does anybody know?
I mean, I think in most cases they did a 21-day period, I guess, to give some time to process, but it wasn't specified for that day 34.
So about 20 days, and then you can just get components out of it.
And then the components, they said, were usually used for operating rooms. So like your ortho cases or things where you know you're going to need blood or trauma cases.
Right.
It was also really cool to see that Cooper University down in Camden was actually on one of the lists. So 19 programs in the country, and we have one right here in New Jersey. And in terms of where the rest of them are, there's a few in Texas.
Well, shout out to Cooper. The John Porter made sure he said this at the state EMS meeting last week, but I already knew he did it, and they use whole blood in their trauma bay, and they're using Reboa. And kudos to John Porter, who runs Cooper, and John Chavonis, who's in charge of their trauma bay.
Yeah.
I mean, John Girones is a big a military surgeon too, so he comes from that world.
The only other thing they said is in the article they just mentioned how most programs have some sort of monitoring system in place where after these patients get this LTOWB, when they get into the hospital, they have some sort of monitoring process where they check haptoglobin levels, LDH for...
Yeah. So obviously, we have to go over an LDH to check for hemolysis, right?
Exactly.
And we used to think that hemolysis was a big deal with whole blood, and it's probably not. I mean, if we read the transfusion article, it's not a big a deal as we thought.
Right, and it's actually about like I think 2/3 of them do that, and the rest of the programs don't really have any specific monitoring programs, and I'm pretty excited for this.
So, I mean, the people who were doing it were telling me they were giving like 2 units, right, for bad patients, and then reassessing, and if they pre-hospital 2 units, and then in the hospital maybe 2 units, maybe or 2 more units, but certainly a lot less than a mass transfusion protocol.
Correct, yeah.
Right.
So I mean, I can't think of all the times during residency where I've actually, said, let's, this patient needs MTP, and then by the time everything's said and done, it's like, hold off now, it's...
Right, and we always
Yeah.
get it
It's a mess.
wrong, right? We'll never be able to get platelets pre-hospital because it's too cumbersome, right? And we'll all be able to get plasma pre-hospital when we get freeze-dried plasma, which the military has, but we just don't have it approved for the civilian world yet. And we know that's better, especially with a study we reviewed on the helicopter program. But we can bypass all that by getting whole blood, right?
Exactly.
And it can save us a lot of money because MTP we get wrong,
Right.
and then it costs us money.
Money and resources too. So if you're in a busy place, a busy trauma center, and you open up that cooler and start taking stuff out, and then you don't use it, and then your second patient comes in from the motor vehicle crash, like you're
Right.
in trouble.
And I've read studies where people say they do 1-to-1-to-1, and if you read what they actually do, they never quite get there, right?
Right.
Of course, there are a whole lot of reasons, but nobody's as good as they think. Everybody always says we try and do it, but we're not successful.
Exactly. And then you just mentioned the plasma, so that was another big issue that's kind of like avoided here. So instead of having to thaw out the fresh frozen plasma, you have the component already there that you're giving.
Right.
So is the breakdown of the blood into the blood products, is that going to be the limiting factor on this? The places that can't do it?
Well, I think that although this has been talked about since I think a conference in Norway, if I remember right, 2011, did it say that?
Yeah, it did.
Right. So this is not new, right? People have been talking about this at blood banking meetings for like years. And again, as we talked about, we got this right in Vietnam and before, in the 70s, right? We were all giving whole blood. I think that's true, but even like for our whole blood, many centers that want to start whole blood are just starting it now. So they're actually getting it from other places into their center before they start the process of, my guess is in the future we'll have on most supervisor vehicles whole blood, right? I mean, maybe that future is 10 to 20 years for some people, but hopefully it can be in the next 5 years. If you think about it, like it kind of makes sense.
Mm-hmm.
Why are we giving crystalloid? But we all do, right?
Yeah.
Well, that's another situation.
Right. So can we, do we all agree that we shouldn't give crystalloid for hypertensive patients, period?
Hypotensive trauma patients and bleeding patients?
How about hypertensive, how about non-compressible trauma, non-compressible truncal hemorrhage in the face of hypotension, which we'll define as no radials and ultra?
Yeah, I think definitely. I mean, it just doesn't work.
Now, we really don't know what we're doing. And then we give 30 mLs per K for septic patients based upon terrible, terrible studies. And several studies which show worse outcome.
So if we're not going to give epi and cardiac arrest, and we're not going to give fluid to hypotensive patients,
Well, you know what the
are we
saying
going
is,
back to just
don't
good
ju-
BLS?
don't just do
We
something,
know it
stand
works.
there. Right? Don't just do something, stand there. Well, but we know for trauma patients who are hypotensive with non-compressible truncal hemorrhage probably benefit from us staying there and putting a Reboa catheter in so we don't deliver a dead patient to the trauma center.
But that would require an MD in the field as opposed to...
No, we just had the first pre-hospital Reboa conference and people want to start doing this pre-hospitally. London Ambulance Service does it.
Paramedics do?
They have a physician, but the paramedic is participating in it. But people at our conference 2 weeks ago were all discussing how we can start doing this in the field. But again, these are people who are going to die, right? These are not people who are borderline, right? So just as much as you and I have been taught trauma's load and go, you know, maybe we should say if loading and going means the death of the patient because they're about to go into cardiac arrest from blunt trauma, maybe we should stay, because if they were in the trauma bay and they coded, many people, though not all, will get a thoracotomy, but we know like thoracotomies for blunt trauma is a death sentence. We know those people do not survive.
And we should go back to mass trousers.
Yeah, no. We did that with no science, right? It's just interesting what the science is and what it's not. But I mean, we're not talking about but think about it. We're by doing less is more, right? Less is more. And these people need to be resuscitated, but they need to be resuscitated with the right fluid. That's all we're saying, right? Again, if your blood pressure is 50, but with that said, there's no randomized trial as far as I know when your systolic is 50 and you have non-compressible truncal hemorrhage to give nothing or give crystalloid, right? And the reason probably no study never will be is both those populations are going to have a bad outcome.
We're assuming that we know for sure that the reason his blood pressure is 50 is because of a non-compressible trauma, truncal trauma. We don't really know that for sure. We're assuming that. So
Well, we're
maybe if
assuming
we find a patient who really is in cardiac arrest or a PA, but it's really not cardiac arrest, just the blood pressure is so low, and the reason for it is because of sepsis or some other thing that is not non-compressible. And we find that by giving these fluids, we bring these patients back, and we're able to get them.
Right, but I can differentiate without that much difficulty in a septic patient whose blood pressure is 50 versus somebody who's just in a bad MVC with ecchymosis on their abdomen, his blood pressure is 50. Right? I mean,
True, however, this person who's in the bad MVC may have caused the MVC because he passed out because his blood pressure dropped.
right, but most of those people who get vasovagal and MVC, their blood pressure bounces back pretty quickly. And right, I mean, a few of those patients, albeit not all that many, will be subjective, right? But most of those blood pressures bounce back pretty quickly, right, when you vasovagal.
Sure.
Right? We think they're getting better because we gave IV fluids. They're getting better if we did nothing. If we stood there and did nothing, their blood pressure would return.
However, this patient may have some manifestation of POTS, and he may just be in an orthostatic position where his blood pressure dropped. And that patient would do better with the fluids.
Right, but the
Take that
incidence of
chance.
postural orthostatic tachycardia syndrome is very rare in the general population, right, in all comers. And you're also having a POTS exacerbation at the same moment that you're riding in your car having an MVC.
We're taking that same line of reasoning about where in the general population, and we're saying it's okay to give LTO plus WB, when in essence you may have an RH negative patient who may have a bad reaction to the LTO plus WB.
I know, but it's been looked at and they don't. They don't seem to,
These
right?
patients do
Or
very
is it
well.
just because there's so few of them, therefore we assume everybody's RH positive?
Oh, but you have data that goes back, decades and decades where pregnant women got this and they did fine.
That's RH positive even though they're RH negative.
Right. Right. Anything else with this article?
The only other thing was that they actually did this in pediatric patients as well in most of these scenarios.
Right. Did they all get like 10 per kilo of blood?
I think
I assume we're giving 10 per kilo of packed red blood cells for a transfusion for a kid, right? I'm sure it would be the same for whole blood no matter what, right?
right, and some of them had a weight. Some systems had like a weight limit where they said they needed to be at least 3 years old or 15 kilos in order to get it. Maybe for, I guess, ease of transfusion. I'm not really sure, but
I'm not sure, but I mean, maybe the incidence probably of pediatric trauma, you don't have that many patients.
right.
That's just it. I mean, many of these things we're just never going to have randomized controlled trials for. You're not going to have two randomized controlled trials for people with systolic 50 who get crystalloid versus whole blood versus nothing, right? There'll never be enough patients. By the time you enter them into the study, they won't be alive anymore, right? I mean, they're all going to have bad outcomes. We're not going to show differences between the group, right? But we do know from that study that was presented today, they had better lactates. The lactate returned to normal quicker, right? That's why I think if the only endpoint you care about is mortality, then, I mean, mortality is an important endpoint, but if that's all you're looking for, you're doing the wrong study, right? Because especially in a sick population. But lactate returning to normal quicker, to me, we're doing something right? We're trending in the right direction, right? And step 2 may be to show a difference in mortality or morbidity. Was anybody in New York on your list using whole blood?
Not yet.
All right. So,
Will we get paramedics carrying whole blood?
no, what I want to do is I want the supervisor to carry it. I want to start with the supervisor carrying whole blood. That's what I'd like to happen. You know, our problem in our areas, we're limited by geography. If you're in an enclosed city like Houston and you give it to somebody, right, then the supervisor's out on the road and they can start the whole blood route to the hospital. And then if they get stuck in traffic, then, you know, so people from non-compressible truncal hemorrhage die within 15 minutes. This was Holcomb study, right? We talked about a study a lot. And within 15 minutes. So when you have your trauma on the street, are you going to be in an OR within 15 minutes? You're not, right?
But we may have a faster response by MD 1, 2, 3, or 4 than we will by a supervisor who's covering a much larger area.
The thing that I found the most interesting, actually, now that you
But maybe not, right? I mean, so we want to carry the blood, period, right? So that's easy. But the problem is it's based upon your geography. This might work well in certain cities, right? But may not work well in our area to put on all the units. It may not make sense. So I think, you know, you start in baby steps and you see if you can start on like a supervisor vehicle. And I think over time, that 110 hours of the blood box might go to 120 hours, might go to 200 hours. Of course, this is a device which you're not plugged in, right? You don't need the Shoreline for it, it's perfect. And maybe somebody will figure out how to make whole blood last for 40 days or 50 days, and maybe the blood component will be like an easier operational status. So this will be even easier. And then, of course, the price has to ultimately come down for us to use it routinely, because this is not going to, the finances, we're not going to make more money by doing this, right?
What is the status of the development of synthetic whole blood?
Of synthetic whole blood?
Yeah.
Yeah, so we had many hopes for like HemeCon and other things, right, for decades and decades and decades. And then through a whole series of events, it turned out that we don't have it. But I think that whole blood may end that conversation. Just like I think that the whole blood may end the conversation of liquid plasma, for people. I don't think it'll end the conversation for freeze-dried plasma, because I think freeze-dried plasma could be readily available for multiple medical units for sick trauma patients. And that'll be easy to carry, bam, and the military's doing it, and we should all be doing that. We just need it available to us. But I was ready to, I had my credit card out when the HemeCon, when we were going to buy it, and then that all fell through. All right, anything else? Well, can we do one more quick one?
I think I should do mine.
Do yours?
In
Okay.
relation to Jocelyn's
Yeah.
article. Yeah.
Okay.
So,
Let's do it.
Again, this article is about LTOWB.
Right. I want to say like LWAB, but it's not, we get it.
So,
L12s.
like Jocelyn briefly mentioned about this program in the meeting earlier this morning. So one more concern about using the whole blood, all positive whole blood, is that the isoimmunization, especially in the female trauma patient with the childbearing age, because one of the most concerning consequences of the all positive whole blood transfusion is hemolytic disease for the babies and fetus. So my article, that this was studied out in South Texas, and then they were trying to develop the transfusion protocol for the pre-hospital helicopter team, and then they wanted to assess the risk and impact of transfusing all positive whole blood to the population, to the female population of childbearing age, and if that kind of influences after the transfusion. So this study was done in South Texas, and their institute serves 22 counties over 26 square miles, and there are 18 helicopter service covering that region to provide whole blood transfusion to the trauma patient prior to arriving to the level 1 trauma center. And the patient will receive 2 units of whole blood in pre-hospital setting when the patient meets inclusion criteria like obvious physical signs of hemorrhage, and then systolic blood pressure being less than 90s, and tachycardia, and so on. So they reviewed a total of they reviewed their muscle transfusion protocol retrospectively and then looked into that this kind of impact of transfusing O positive blood to those patients. So they reviewed a total of 124 patients, and of those over the 30 months, and of those 124 patients, 26 patients were female, and then 18 of them were childbearing age. And then what they found was that of those 18 women, 16 had blood type and screening, and then only one of those women are RH negative. So they did a calculation, and then authors estimated that the risk of RH negative women, so they estimated with only one RH negative woman of childbearing age in 30 months, potentially getting the LT or LTOWP, and then anti-D conversion rate between 3 to 30%, there would be a risk of isoionization of only 0.012 to 0.12 patient per year. So it's really, really, really rare to get isoionization from receiving O positive blood in those particular high risk patients. So what they think is risk benefit of strongly favors that giving the whole blood transfusion even if the patient had maybe RH negative. And then their philosophy is that better to have a live patient with isoionization than dead patient as a result of a hemorrhage. So they justify giving those whole blood transfusion to these patients based upon their retrospective data.
Right. So there you go, Josh. 0.0012.
Yeah.
But I mean, I forget this. What, 15% of women are RH negative? Is that right?
So
That's what the conclusion here says, yes.
Is that the?
it's ethnicity dependent. So I think where this study was done, this was done in South Texas, but their patient population was 63% Hispanic and 7% African American. And of those populations, the prevalence of RH negative is like 7%. But in white patients, the risk of prevalence of RH negative is 18%. So it's really where you are located and what's your patient population is like.
But even if you're talking about just Caucasian women, you'd still have a very low percentage. Yeah. So do we all agree that it's okay for that doesn't matter that it's negative or positive blood, right? That the risk is so low.
I mean, even with a low risk, like any other procedure that you'd be doing, this is a conversation that you could have with a family member if you have them there, or the patient if they're awake and alert,
Right.
and just say, hey, you may have a reaction here. This may be a problem for you down the line if you're a female of childbearing age. But assuming that the patient lives and survives, why couldn't a patient then get RhoGAM as soon as they got to the ED?
Yeah, of course.
Right?
That's what they discuss in this article.
Exactly what it says.
They actually have a post-transfusion protocol, so they consult the pathology and then OB-GYN whether or not the patient is still, immunoglobulin and stuff.
You know what I'm thinking, don't you? We could carry.
Program on the field.
Yeah.
I know what I was
Saw that look.
What if the family tells you that she's RH negative? Would you still go ahead with the LTO plus WB?
Yes.
Would you do the LTO plus WB and the RhoGAM?
That's where you
For
have that.
non-compressible truncal hemorrhage in somebody who's hypertensive or no radials and altered, yes. I wouldn't think about it.
Yeah.
I would
Yeah,
just
it's
do
a
it.
life-saving measure, and the only problem is with the RhoGAM is that we're going to have to calculate how many vials per unit to give of RhoGAM because it's
Right, and I don't remember. Somebody help me remember this. How many days do you have to give RhoGAM after? Is it 72 hours? Is that what the number is?
before you become. That sounds right. I have the.
Right.
And we have patients who are pregnant who have been bleeding for days on end before they come to us.
Yes.
Who knows?
Some of them are bleeding for more than 72 hours.
Exactly,
Right.
and we still treat.
Right. I wonder if that number is real or that's just something made up in medicine. Like, I wonder if like it doesn't, you know, it's really like 2 weeks that the risk is up, not 72 hours. Right?
Well, it seems it's after multiple transfusions from
Yes.
this article. It's not after a single transfusion. You need to-
Right. But if a woman's bleeding, I mean, that's probably equivalent to a transfusion, you know, of getting the blood to cross the placenta.
Would we do that in the field for a woman who's been bleeding for days and presents in syncope, near syncope, with extremely low blood pressure?
What?
Would we be, if we're carrying whole blood, would we be giving that in the field?
Well, that's the plan.
Not, we're talking non-traumatic,
Yeah, that's the plan.
non-suppressed, non.
Already
Yeah,
5 programs out of the 19 we're doing it.
GI bleeds are included.
Like the thing, if they need it, you know, whole blood right now, because synthetic blood hasn't been working for us yet. Hopefully it will, but how else are we going to carry oxygen in the blood?
Right. But in the words of John Holcomb, it's not the oxygen carrying capacity of blood that's the most important. It's getting the clot. Right. This is why if you have to have a choice between FFP and packed red blood cells, FFP wins. Right. It's more important to get the clot than oxygen carrying capacity.
Yeah. And the whole blood will have all that.
This is why the Reboa, for 15 minutes of balloon up, might slow down the bleeding enough just to form the clot.
Exactly.
Right. All right, that's good. That's 2:15. All right, any other questions? We could stop here. So just remember, May 20th, we'll be getting emails soon for EMS week, and January 2nd for Reboa. We will be back in 2 weeks. After the Reboa conference, we are going to start Journal Club with probably a lot of people down here at the Monarch Education Building. I sent out the wrong address, so I think it was just a typo. It should be 5100 Belmar Boulevard, and GPS is probably Wall, right?
Yeah.
In Wall Township, and that's New Jersey. So thanks for joining us. We will see you January 2nd.